Hi guys, good evening and welcome to these sessions of recalling all the questions which have come in exams, and we are doing Obs and Gynae just now. Wonderful to see that a few of you have stayed up so late for this, and I know you're all tired. But yes, this exam does tell us, NEET exam will always tell us that you have to read a bit to get into your post-graduation. It's getting tougher every year, and the questions which came this time, look, for a gynecologist, I'm living this life, it appears that, okay, if you've read, you can answer. But then people who have to read 19 subjects and appear for a PG entrance exam, we are now expecting, at least the people who are making the exam, they're expecting that you should be reading all these 19 subjects and become an expert in all the 19 subjects. I mean, you should be good enough to be called an MD in all these 19 subjects and then appear for the MD entrance exam. So yes, it's getting tough, but like they always say, tough times make the tough things come out of you, and yes, it is where you have to make up your resolve and read as hard as possible and as regularly as possible and discuss a lot. It has always been easier if you discuss, you talk to your friends, and whatever you read, as much as you can read, but it's always easiest to remember that the common topics you should read in detail now. Don't leave the common topics, and that's what has been proved in this exam of Obs and Gynae. At least some 40 questions came, and I think we've recalled around 20-25 of them here. And if they're not, if there's some questions which you attempted and they're not finding its place in this recall session, please remind us so that we can always use them in the PrepLadder forum for you to come and see the answers somewhere else, if not here. Right guys, so we'll start with the first MCQ, and just to remind you that the rapid revision is launching on 16th of August, and it is your journey where you'll be doing around 260 plus hours of training with us with a lot of MCQs and concise notes. And we are doing this for recall all these questions, a lot of answers, a lot of choices which you students only have given us may not be the ones which came in the exam. But at least I'm sure that you recall the topics correctly so that we can discuss the topics in as much time which we have. So guys, let's start with the first MCQ. What are you guys already sending some messages? Hi, good evening. Yes. Okay guys, let's start immediately. So, first question, a lady with impending eclampsia, Pritchard regime is given. When would we want to stop the treatment? Now, I've always maintained one thing, that if you're reading eclampsia, please read Pritchard regime properly. If you have time, read a little bit about Zuspan regime, which is the IV regime. And Pritchard regime is the IM and the IV regime, and that's the only one which is going to come in your exam, because that's the only one which we give. When we are taking care of an eclamptic patient, we are always giving the Pritchard regime. So there's no point going and reading, digging out what was given in those ancient ages, and please don't pick up the vague drugs which are not even thought of when we are having a patient of eclampsia. Think of magnesium sulfate only, all right, and Pritchard regime. Now, when we are giving the Pritchard regime, all of you know that first is the IV and the IM load of 14 grams. Please mind it, it's the dose is always in grams. So when we're giving the loading dose of 4 grams IV and the 10 grams IM, after that, what you should do, you should deliver the baby. Eclampsia means the pregnancy is had it. Now, you cannot continue the pregnancy anymore because the worst case scenario with hypertension has happened, that the patient has already gotten to the worst case scenario that she's about to die after she's now convulsing, and next thing she's going to die, and the baby is also going to die, the mother is going to die. So now you are at that stage that you cannot continue the pregnancy anymore. So if a woman has eclampsia, you've decided that you're going to terminate the pregnancy. Whether it's a cesarean or a normal delivery, it depends on the obstetric findings at that time. So you have already decided that you're going to terminate the pregnancy. So the Pritchard regime, all of you know, 14 grams is the loading dose, IV and IM, and then you have to give 5 grams 4 hourly for the next 24 hours. when you're giving that 5 grams 4 hourly intramuscularly, that's the one which you have to remember. 5 grams intramuscularly 4 hourly for 24 hours after the delivery or 24 hours after the last convulsion, whichever is later. Now, when you're giving this, please remember 4 hourly you have to monitor the respiratory rate, the knee jerks and the urinary output. Now, why should you see the respiratory rate and the knee jerks? Because magnesium sulfate is a drug which is going to suppress the brain. So, that is what is going to help stop the convulsion. But if you give too much of a dose and if the drug is not getting washed out properly from the body, then the person is going to have a cerebral suppression and the respiratory rate is going to fall and the knee jerks are going to get absent. But one more thing you have to see is the urinary output. If the urinary output is less than 100 ml for the last 4 hours, so you're giving it 4 hourly, urinary output should be at least more than equal to 100 ml in the last 4 hours. Why are we worried about the urine output? Because you know magnesium sulfate has a renal excretion. So, if the magnesium sulfate is not getting cleared properly, then there is going to be side effects, that is magnesium sulfate toxicity. So, that is why the answer to this question, what have you guys answered? Okay, good evening, good evening, good evening. Respiratory rate is more than 18. No, that's not the answer. Respiratory rate, we can say that the respiratory rate should be at least 14. So, anything more than 14 is all right. So, 18 is comfortable. So, some people say 12 and some people say 14 is the cutoff. So, if respiratory rate is less than 14, I will not give the next dose of magnesium sulfate. If the knee jerks are suppressed, I will not give the next dose. If the output is less than 100 for the last 4 hours, I will not give the next dose. That is what you have to do. So, yes, the answer here is that urine output is less than 60 ml in 4 hours. No, this is wrong. Urine output is less than 100 ml. So, yes, that is where we are going to say what would be when we stop. So, when the urine output is less than 60 ml, then I am going to stop the treatment, because at least 100 ml should be there. It is less than 60 ml here. So, this is the one which is really bad. Less than 100 would have been bad, less than 60 is worse. So, that is the answer here. Serum magnesium level was answer. Serum magnesium level. Okay, I don't know what was the serum magnesium level which was given. So, I can help you that serum magnesium level, you know, is 4 to 7 milliequivalents per liter is the therapeutic level, and 8 to 10 milliequivalents will cause knee jerk suppression, and more than equal to 15 is going to cause respiratory arrest, and more than equal to 25 is going to cause cardiac arrest. So, even if that was in the values, I am sure you can now remember what was given in the exam and you can get your answers. All right. So, don't worry about this. Serum magnesium level is given, the fine magnesium level was not there. Okay, fine, you guys decide. The respiratory rate less than 14 was there. So, now you are confusing me. Okay. Anyway, so that's the fun of having a recall. Whatever you guys are writing, the PrepLadder team is going to see that and going to make a proper question for the ultimate presentation in the PrepLadder app. For the time being, you have been given the correct values for the respiratory rate, for the output and for the knee jerks. So, whatever was asked in the exam, I am sure you got it correct. All right, guys. So, in the current scenario, the question which was recalled to me, urine output less than 60 ml is bad. It should be at least 100 ml. Less than 60 ml is still worse. Okay. So, let us go to the next question. This was a fairly simple one, but yes, you have to remember the milliequivalents, you have to remember the regime properly. Whenever you are reading eclampsia, please read the magnesium sulfate dose also, and the treatment is with calcium gluconate, how much of calcium gluconate you should give. Please read the full detail of eclampsia. Eclampsia is rampant in the poor part of a country. The people in heat, humidity, poverty, that's what we say is the ideal concoction. And the peninsular India, wherever there is humidity and heat, humidity, poverty, okay, and anemia, that is the ideal concoction for getting eclampsia in pregnancy. And this is rampant in the peninsular part of a country. Those of you who are in Kerala, those who are in Tamil Nadu and in West Bengal, Goa, Mangalore. Of course, Mangalore, the people are, slightly better off. So, you don't see that much. But yes, in the peripheries in Mangalore also you will see. So, there are a lot of places where you will see eclampsia, where there is heat, humidity, poverty. All right. So, think about that in your mind. So, method of delivery in A and B. I assume that this is fetus A and this is fetus B. or you can say the one is lower is the A and the other one is B, but both these babies are in cephalic. So when there is a twin gestation, the most common presentation twin gestation is both cephalic, and the second most common is first cephalic, second breech. Now, what are you going to do when both the babies are in cephalic presentation? Now, I mean, there cannot be a simpler question in twins. What have you guys answered? Okay, 2 pregnant females. Oh God. Okay, Dr. Lulu, hello, good evening. And you're saying 2 images were given, and one was in breech and the second was in transverse. So, guys, if this was the picture, okay, fine, let's take one thing at a time. If this was the picture, we'll do normal delivery. Now, if first in twins, very simple, first is breech, I will do cesarean section, no doubt about that, because if it is a singleton breech, I will do a normal delivery, whether it's a primigravida or a multigravida. In an institution setup, breech should be given a trial. End of discussion. Now, if it is a twin with first breech, it is called a complicated breech. So, twins and first breech do a cesarean section, no doubt about that. Now, if it is twins and the first is cephalic and the second is transverse lie, I will do normal delivery, no doubt about that. First one normal delivery and second one I'll do an internal podalic version. Yes, we have done it n number of times, and I don't know how many cases of IPV have done for a second of twin and transverse lie. It is absolutely a very simple procedure in a person who is experienced, and it's a very easy time to do an internal podalic version. Why? Because the uterus is relaxed after the first labor. All right. So please understand that even if it is second transverse lie, yes, of course, if it is a twins with the first baby, twins with first having a transverse lie, then you'll do a cesarean section. All right. So I've given all the combinations. I hope all of you see that, and then we'll move on. Yes. First cephalic and then second transverse. I'll give a normal delivery. Both breech, I will do a cesarean. Yeah. So you guys, all of you have given me all the options possible in twins. So that's why we discuss all the possible combinations as well. So let's move on. Otherwise, you guys will go on asking about what came in the exams. We are not worried about that since the recall is not perfect. So we already given the answers. Flexion point into Ventos delivery is, so if the head, if you see, and you got the sagittal suture here, and if you're going to put the Ventos, so where are you going to put the Ventos? Suppose this is the anterior frontal is here and the posterior frontal is here, the triangular one, and this is the anterior part of the fetus and this is the posterior part of the fetus. Then where are you going to put the vacuum? So the vacuum is going to be applied on the head at the level of the sagittal suture, and you generally apply it around 2 to 3 centimeters from the posterior frontal. So this is the posterior frontal, and 2 to 3 centimeters in front of it, you're going to apply the vacuum here. So what are the choices we have here? 2 to 3 centimeters. You don't have a, you're putting a cup into the vagina, and the head is filling up the vagina. So you're not going to actually measure it or something like that. It's with your experience, you know that you're going to put it at the, the upper half of the head, so that when you pull the head down, it's going to cause some flexion of the head, and then you pull out, is going to cause an extension for the delivery. So that's how that flexion is maintained throughout the labor. But when the head is delivering, the head delivers by an extension. So to help the descent of the head, you'll put it on the top of the head around 3 centimeters in front of the posterior frontal. You help the flexion and you pull the head out easily. When it is coming through the perineum, then you pull it up with extension, because normally the head comes out with extension. So yes, the answer here is 3 centimeters posterior to the anterior frontal, 3 centimeters anterior to the posterior frontal. According to the information sent to me, I will mark B as the answer. All right. Oh, the first shift, second shift. Okay, I can understand. First shift, second shift confusion will also be there. So, oh God, then you should have been giving me 80 questions, man. There should have been 40 questions from shift A and 40 questions from shift B. All right, it would have been, let's see how many questions come to us eventually, and we'll discuss all of them in the PrepLadder forums. So, flexion point in the Ventos delivery is choice B. Right, let's move on and see this question. Anticoagulant of choice in pregnant female at 30 weeks of gestation is. So a lady is pregnant and she's probably having a, let's say, a replaced mitral valve, was having a deep venous thrombosis. You have to keep the patient on a a thromboprophylaxis, and if there is a DVT, then you have to give an anticoagulant, and we can prevent thrombus formations in replaced mitral valve patients by giving a prophylactic anticoagulant. So what is the best one? So a lot of research has gone for a lot of agents, but what is written in books? Now that's where the easy part of your discussion is. So the books are Williams Obstetrics and Gabby's Obstetrics, and the reference books, reference notes which are given from institutes in our country. Those are the books which we should be referring to. So we cannot say that this journal is giving us this information and it was mentioned in the latest updates of the American Journal of Obs and Gynae, or from the Royal College there's a latest update. All of that doesn't make sense as long as it is not come in a standard book for reference, or it is not accepted by the health ministry of a country. That's how we give you answers. Okay, otherwise for every disease there are 10 different drugs which are given as a drug of choice by 10 different concerns, 10 different bodies. So that's why I'm saying. So anticoagulant of choice in pregnant female at 30 weeks of gestation. What have you guys written? Low molecular weight heparin was a choice. What else was a choice? DVT and prophylaxis to prevent pulmonary embolism. Correct. So I assume it was DVT. That's why I said DVT, although it is not mentioned in the recoil. So if it is a DVT, anticoagulant of choice, please remember we can always think of warfarin as the best drug because the effect is much better than giving low molecular weight heparin or unfractionated heparin. But the problem is, in the first trimester, you know that warfarin is going to cause an embryopathy. It causes, corneal atresia. It causes a lot of problems. So that's why we say that it's better that in the first trimester we don't give warfarin. So first trimester we give heparin, whichever form you want to give, and then after 12 weeks we will put the patient on warfarin. And now, when do you switch back? I think that question also somebody has recalled. So after equal to 36 weeks, because she's going to now get into labor anytime. So then we will switch back to heparin. Why do you want to switch back? Because when the patient is, let's say, patient is going to be induced at 39 weeks or 38 weeks for whatever reason. So that time, if you stop the low molecular weight heparin even one day before, the anticoagulant action will wear off and the patient won't have too much of bleeding in labor. But at 38 weeks, the patient is on warfarin. There is no harm to the baby. But if the patient is on warfarin, if you stop, then the effect of warfarin is going to be there for another 1 week to 10 days. So that's why around 36 weeks, you must stop the warfarin and change the patient to heparin again. So that's the recommendations which we generally follow. So warfarin, the number of studies which have been done and the kind of effect we've got on patients, warfarin is the drug which I will be giving. Okay, at 36 weeks. Okay, so fine, if it is 30 weeks I will go with warfarin. If it is 36 weeks, if they ask 36 weeks, then I've already given you the answer. Then you go with heparin, that I've already written in this. So I guess all your combinations have been answered which were asked. Chalo, not to worry. Let's move on and see the next question. Pregnant lady at 37 weeks period of gestation came for normal antenatal checkup. She is currently on warfarin. What would be the next step? So there, the second combination also have been given. So when she is on warfarin, you will change the patient to low molecular weight heparin. The I think morning shift and the evening shift, those two, both the question sets have come. So you know the answers well to this. Let's move on. See the next one. Female presents with postcoital bleeding. Which of the following is the most appropriate investigation required? Come on, guys. Now, my students, I want to know what you have answered. Come. I'm very interested in this question. Come. I'm waiting for your answers. Postcoital bleeding. I'm waiting for this answer. Cervical biopsy astrophile. Pap smear. Somebody said C. Are you sure it was HCV DNA or HBV DNA? I'm sure it should have been HPV all the while. It should have been HPV. I think mostly it should have been HPV, but since it is not written, I'm sure it was. First of all, please tell me whether it was hepatitis B or hepatitis C. I hope it is not the choice. I'm very, very sure it would have been I'm sorry, human papillomavirus. HCV? HCV was there? Don't tell me, guys. Co-test was also there. Guys, now you're really, really confusing me. Cervical erosion is another question, astrophile. There's another question which has come about cervical erosion. That is somewhere else. HCV was also there in the options. Look, guys, let's make it simple for you. Whatever are the options, see, that's what happens, that only in PG entrance questions, they don't release the question paper. The Ministry of Health and Family Welfare and the Education Ministry, I think they'll do a very good favor to all postgraduate entrance students, that the big institutes are making these MCQs and they should release the MCQs the following day. Don't give us the answers, we'll find out the answers obviously, but at least give the questions. So they'll reduce a lot of confusion in life. So we'll know what they're asking at least. Okay, the answers we can, sort out a little while later. It'll be a good, I mean, if somebody from the, the education ministry is seeing this, seriously, it's a request that all the questions can be given. Even in NEET UG exam, they give the questions the next day and the students know how much they're going to get. Yes, there are a lot of controversies, but what if the big institutes make the MCQs and what answers they are expecting us to give? We can all sort that out and make a much easier life for all of us. Anyway, so let's go ahead and see what you're going to do when there is postcoital bleeding. When there is postcoital bleeding, please, pap smear is not the answer. I hope nobody has given that. Liquid-based cytology or doing pap smear means doing a cytology. That is as a screening procedure. When a person is symptomatic, when a person is having intercourse and then she's bleeding, that means there is a contact bleeding on from the cervix. That means she is symptomatic. And you know the basic principles that when a patient is symptomatic, go ahead and do a definitive diagnostic test than a screening test. So please, postcoital bleeding, I know a lot of places you've been telling me that it is pap smear. No. When a patient is symptomatic, having a postcoital bleeding, I'm going to put a bright light into the vagina and I'm going to do a magnification with a colposcope and look at abnormal places, whether it is with a magnification alone or I'd use Lugol's iodine or use acetic acid, and I'm going to look for abnormal sites and I'm going to take a biopsy. So please remember the cervical biopsy, wherever, whatever choice at cervical biopsy, I'm going to mark that. So I will not go into the confusion now whether it was HCV, HPV, HBV, because it's only adding to the confusion of the recall. So I hope all of you got that. Why don't they reveal the questions exactly, right? Some other time. There is a postcoital bleeding question, Sudeep, and there is a erosion question. Okay, guys, the erosion question is coming. Okay, we'll discuss that later. Okay, suppose this was the question, this is the answer. Let's sort out this and let's move on, guys. Don't waste your time on the chat too much regarding what question came. If this was a question, that's the answer. Let's take another question. Pregnant woman presents with history such of hyperthyroidism at 8 weeks of period of gestation. What is the drug of choice? 8 weeks. So you cannot give drugs which are causing teratogenic actions like methimazole, carbimazole. These are excellent drugs. They actually have better action than propylthiouracil. But remember, when there is hyperthyroidism, the best drug in the first trimester is the one which does not go to the fetus and cause teratogenicity. So the answer is indeed propylthiouracil. So you give 150 milligrams or 100 milligrams tablet twice or thrice a day, up to 300 to 450 milligrams of propylthiouracil you can give in the first trimester. Yes, it is hepatotoxic to the mother, but it is not teratogenic to the fetus. After 12 weeks, you can switch to carbimazole. That's fine. It can cause a lot of teratogenicity. Okay, it can aplasia cutis it can cause, and the problems are so many that we always think that it's better to give a safer drug in the first trimester. There is some discussion that you can give carbimazole in the first trimester also, but there is a lot of discussion in the journals. So when we see Williams Obstetrics, we are very clear. So yes, we have been discussing about use of carbamazole in the first trimester, and accept that there are some problems, but the benefits of the drug are more than the risks of the drugs. So all that research and the discussions which are in the journals, we are not discussing in this forum. You have to know pakka core basics, and that is propylthiouracil in the first trimester, after first trimester carbamazole, as simple as that. Now somebody has asked me, sir, if they don't give first trimester, second trimester, then throughout pregnancy what is the drug of choice? Obviously you have to answer propylthiouracil, because it can be given in the first trimester. All right, so let's not beat about the bush in this anymore. Let's move on. So next question is, now I don't know what was this picture, but this is obviously recalled by the PrepLadder team. What is the diagnosis of a gravida 2 para 1 live in woman with a history of a hysterectomy? A woman had a hysterectomy, and this specimen of hysterectomy, I mean, it looks like that, yes, there is the uterus here, you can see the tubes here, and it looks like the placenta is very badly stuck and it was not removed and it was bleeding too much, so a hysterectomy had to be done. So in the current, I mean, I don't know whether you can see the picture properly. Yes, it looks like that there is a, there's a complete, this is the whole placenta which has stayed back and it is invading into the muscle of the uterus. So to me, it looks like a straightforward case of placenta accreta. But one of my students, he called me yesterday itself. He said that there was a very obvious picture of an inverted uterus. He was recalling that how I taught in the class that there's a picture where there was an inverted uterus. Exactly that picture was there. So was it inversion picture, guys? Covulate uterus image was given. Now this doesn't look like a rupture uterus to me. I mean, it looks like a uterus where there's a placenta which is invading into the uterine muscle. So it looks like a placenta accreta in the picture which is given to me. And an inversion uterus, obviously you know that the uterus is like this in the vagina normally, but if it inverts like this, okay, the uterus comes out after delivery. So that is what is a inversion. All right, so this is inversion. It looks something like that if they ask you. And of course rupture uterus will be a much easier picture. So what is it was mentioned that there was bleeding while attempt to remove the placenta was made. All right, while attempting to remove the placenta there was bleeding, goes in the favor of placenta accreta. Previous studies now present with antepartum hemorrhage during placenta delivery, increased hemorrhage during had to do hysterectomy. This is all suggesting placenta delivery was not successful. So this is all the features which Dr. Bharat Kumar, Dr. Lulu and Dr. Saha have recalled. It is suggesting that the patient is having a placenta accreta. So if the inversion was a question, inversion can cause sudden shock, and that is because of the bleeding and also because of the pain. So neurological shock and hemorrhagic shock are the causes of death in inversion, and the most common cause is hemorrhagic shock. This obviously is the case of placenta accreta, and remember placenta accreta is related with previous LACS, but more commonly it is related with placenta previa. Right. So the next question, teenage girl presents with a history of amenorrhea. Okay, an image is provided showing a imperforate hymen. I don't know whether that image is here. What karyotype analysis would you consider for further evaluation? Was this the question? Since no image was given to me from the PrepLadder team, so I don't know what kind of image came, so you can discuss. I can wait for your suggestions for this one. What did you guys answer? So the image looked like it. Image did it look like something like this, like an imperforate hymen like this? Imperforate hymen will be something like this. There'll be a imperforate hymen here, and the blood will be accumulating all over the place. Let's see. It'll be something like this. This is how a imperfect hymen will look. And imperfect hymen patients will generally come with severe abdominal pain, monthly pain, 3-4 days, and then eventually they'll come to you when the vagina gets so distended that it presses on the urethra and causes retention of urine. Many times they come in an emergency with retention of urine. A case of primary amenorrhea coming to you with retention of urine at 2 o'clock in the morning. My PG calls me up, and so many times we have diagnosed this on the phone, that did she have a period so far? 16-year-old girl not having, having retention of urine, has come in the middle of the night. First thing I always ask, did she have a regular period so far? So many times we've diagnosed this on the phone. But yes, if this is a case of imperforate hymen, what was the question asked? What kind of karyotype you are expecting? Was that the question? Okay, normal breast and hair development. Okay, so normal breast and normal hair development and primary amenorrhea and a picture like this. So I am expecting a karyotype of 46XX. That's what I am expecting. So that is just probably the language would have been much more clearer. Yes. Okay, fine. I think this is a. All right. So first shift, second shift confusion exists. Okay. A pregnant woman has just delivered a healthy baby via normal delivery. What is the earliest time at which an intrauterine contraceptive device can be inserted? Was this the question? That's the first thing. When can you earliest do it? Because there is something called a PPIUCD. So immediately after delivery, you can insert. You can do a person had a normal vaginal delivery, the placenta is taken out, and then we have a long sponge holder these days. We go and place the IUCD inside at the fundus. That's what we do. So we can do it immediately. Or we do a cesarean section, and during cesarean also we can place an IUCD at the fundus and come out. So you can do it as early as possible. As the person delivers, you can put the PPIUCD. So PPIUCDs can be put up to 48 hours. That's what they say. So within 48 hours looks like the answer. But I don't know what was the language, because if they say after delivery when an IUCD can be placed best. So if you ask me something like that, I'll say after 6 weeks is the best time to put an IUCD, because the uterus has gone back to its normal size. Then if you put an IUCD, the retention is more than 99%. But if you put a PPIUCD, the expulsion rate is up to 12%. That was also NEET exam question. What is the expulsion rate of a PPIUCD, postpartum IUCD? That is up to 12%. So what is the question? Within 48 hours, yes, same question. Within 48 hours, at least make a video and post on your channel about the RG car case. Akash, I know. You're digressing from the issue here today, but my heart bleeds every time I see something like this happening, and it is very, very disturbing to see what has happened. And all us doctors have praise in our mind for the family and sympathies, and a lot of anger for what happened, and it should never happen. My friends who are here from who are watching this from RGCAR, I've taken a session for you, PrepLadder session for 2 days, and if they are watching this, I'm thanking all those boys and girls who took care of me, because I was having high fever for those 2 days, and you guys took me to your casualty in RG car and you took care of me at that time. So I have my full sympathies for, I mean, not just because it's your place, it's for anybody, anybody having a problem like this, anybody undergoing such devastation. We have our sympathies and anger at the same time. But since it's our own doctor, and doctors should be having more protection, we all agree, and we are with you in the protest. Okay, so we are in a different forum, my friend. Let's stick to the point we are here for, right? So my sympathies to everybody concerned. Okay, so 48 hours pregnancy with IUCD in IUCD best option. Next time it is one option was 48 hours to 6 weeks. The second option, uterine pregnancy with IUCD in situ. That is the second question. All that discussion about next we'll do at some other forum. A lot of doctors are making special videos for all of that. So let's stick to the topic we have. So if a patient had delivered and we are putting, I don't know what was the language asked, but if it is within 48 hours, if it is PPIUCD, if they asked you, then it is within 48 hours. Okay, so I will go with this answer in this question. But if they said that after delivery, what is the best time to put an IUCD for best effective retention, then I will say 6 weeks. So depending on what question was asked, since nobody is able to give that, so yes, we'll go with the first choice as of now. Choice A is the best answer. Okay, guys. At ovulation, what is released? Yeah, this is a question which I like a lot. What is released? An oocyte is released, obviously. So when a oocyte is released, how many oocytes are released? One oocyte is released. See, one oogonia makes one oocyte when we read about gametogenesis, whereas one spermatogonium makes 4 spermatozoas. Okay, so one oocyte is released at the time of ovulation, and it is what phase of the meiotic division? It's a second meiosis. So it is a yes, second meiosis I've already given you. Okay, I think that's the answer then. choice D. So it is a metaphase 2. It is a metaphase 2 oocyte. You know, we in IVF always write it's a M2 oocyte. Okay, that one polar body is released, it's a metaphase 2 and it is arrested. So now this will resume only after fertilization and the second polar body will be released. So first polar body released at the time of ovulation. Don't say before, I mean 1 day before, you know, there can be, but traditionally what we are expecting you to answer, when the oocyte ovulates. When ovulation happens, it is a metaphase 2 oocyte and polar body is released at that time, at the time of ovulation, you should answer. And it is a metaphase 2 oocyte. Second polar body released after fertilization by the sperm. Right. It was little tricky. I was primary and secondary. Okay, options were slightly different. All right. Look, okay, so if there is DVT, and if there is DVT, obviously in acute management, see, we are talking about DVT when it is already diagnosed. But if you're giving, always acute management is done by heparin, and we always switch over the patient. Once we get the desired result, we switch over to, but that question was not asked. Okay, we switch over to warfarin because that will give us more sustained action, and we'll be getting a more a definitive action with warfarin. Okay, so we agree to what you asked. Next question, time between fertilization and implantation. Yes, I always tell you that the first chapter in PrepLadder, the app and the wherever we've met in live discussions, I've always told you the menstrual physiology chapter, which is 2.5 hours of discussion. I've always told you, please, 3 to 5 questions will come from that one chapter, whether it is from gynae or in physiology, you'll get those questions. So this question is between fertilization and implantation. Earliest the implantation takes place on the 6th day, but here the options are very easy. From fertilization to implantation, 2 days, 8 days, 14 days, 16 days. So go ahead and write 8 days because this fertilization implantation, earliest implantation takes place on the 6th day after fertilization and can happen till the 10th day after the fertilization. So 6 to the 10th day. So that 8 days is the answer to this question. Yeah, this one was a fairly easy one. Okay, let's move on and see the next question. Identify the tears shown below. So I don't know whether this was the picture here because this is a picture where I can see only the vagina and the anus here from the front. So whether it is involving the rectum, I cannot make out in this picture. It should have been a more well described picture, but it doesn't look so clear here. So with this picture, it looks like a 3rd degree tear, and if it is rectum involved, it is a 4th degree tear. All right. So what was the question here? 5 days was the option. Yeah, then 5 days you can write. How to subscribe you to get more important topics in future? Milind Sejwal, you can always write to me personally, drprassan@yahoo.com. There is PrepLadder forum, and I'm there in a few places where I take classes. Otherwise, if you don't want to do any of this, just write an email to me, Dr. Prassan, Dr. Prassan. I'm not Prasanna, okay? I'm Prassan, Prassan. Dr. Prassan@yahoo.com. Send me your queries, and email is the best method to stay in touch with me. I'm very slow on Insta. I'm pathetic on WhatsApp because I'm working also. So whenever I'm at work, I can see the messages on the email, and I can always give you an answer eventually. If not in an urgent emergency, I won't be able to answer you, but I can eventually answer you if you ask me on the email. Right. So what is this 3rd degree tear? It looks like a anal tear to me in addition to a perineal tear. So 1st degree tear is involving only the vagina. 2nd degree is vagina plus the muscle. 3rd degree is vagina plus muscle plus the anus. And 4th degree tear is all of these plus the rectum. All right. So here it looks like the answer is 3 because I cannot see if the rectum is involved in this picture. That's why I'm saying it is a 3rd degree tear. But remember, 3rd and 4th, both are known as the complete perineal tears. Both are known as the CPT. Okay. Now, in this third degree tear, this anus is divided into 3A if it is less than 50% of the external anal sphincter, and 3B if it is more than 50% of the external anal sphincter. That means almost completely external sphincter is gone, and 3C if it is external anal sphincter plus the internal anal sphincter. All right. So, I don't know what was the picture here. Rectal mucosa was involved if this, then it is a 4 degree tear. Oh, rectum was, I mean, the picture given to you was clearly involving the rectum, right? Okay, fine. Then it is a 4 degree tear. Anyway, all that information we've discussed here. Tubectomy question is coming up, my friend. We are having a tubectomy question. Identify the instrument shown below. So, I don't know what forceps was asked. Was this the forceps? Please, I'm saying picture 1 or picture 2. What was the forceps asked? Picture 1, picture 2. Which was the forceps asked? Can you please answer 1 or 2? Because both are different. I got the picture sent to me by the team was the first one, and the one which I think should have been asked to you is the second one. I feel this should have been the question asked to you people. I mean, like, I like this forceps a lot. The one which is here, it's one of my favorite forceps, but okay, I'll wait for you. Piper forceps. This doesn't look like a Piper's forceps to me. It's way too long to be a Piper's forceps. Yes, Piper's forceps does have a lock like this. See, if it is so long, it cannot be Piper's. It looks more like a Keelan's rotational forceps to me. But if they asked a Piper's, it should have been a short forceps. It's a short forceps without any uh, pelvic curve. Piper's does not have a pelvic curve. It just has a cephalic curve. So that should have been a better picture given to me. So Piper's is what I think they should have been asking you. Piper's or Wrigley's. These are the two forces which are generally used even in practice nowadays. The rotational forceps, some senior people will be doing rotational forceps, definitely not junior residents and senior residents. So yes, rotational forceps is applied even now. And rotational forceps, when there's a head which is from occipito-posterior has come to occipito-transverse, and it is not a neglected occipito-transverse, you can put rotational forceps, and that is Keelan's. But Piper's is for after coming head, and Wrigley's is for a outlet forceps. So yes, this second picture, this is a Wrigley's forceps, and Piper's will be a little shorter forceps than the picture given to me here. So anyway, this looks like a Keelan, and if it was Piper's, then it should have been a little shorter picture given to us. Two pictures after coming head. Okay, after coming head, Piper's forceps, fine. That is correct. If you know that, fair enough. I'm just answering the picture which was sent to me. Never mind. Let's move on and see other things. What could be the cause of a 2 centimeter black nodular mass near an episiotomy scar that is painful, increases in size during menstruation? There's a swelling on the perineum in a old episiotomy scar. It's like this. It's here. There's a black nodular mass here. Don't think it's in the vagina. Don't think it's here. Okay. So there is this mass here. Okay. So what is it going to do? So yes, this is every time she's menstruating. That means this area inside, this nodule also is menstruating within inside. So yes, this is a typical presentation of a scar endometriosis. Scar endometriosis can be there in the abdominal scar of a cesarean, or it can be in the episiotomy scar. So scar endometriosis, the endometrial gland has found its way into a cesarean scar on the abdomen or in the episiotomy scar, and every month with the estrogen in the body, this area proliferates. With the progesterone, it secretes, and when the progesterone withdrawal happens, there is a bleeding in the vagina because the uterine bleeding will happen there. But this scar in the episiotomy or this scar in the cesarean incision, this nodule in the cesarean incision, this will grow every time and become bigger. With every menstruation, these areas will become bigger because the blood in this episiotomy cannot go out. So it will become bigger with every menstrual cycle. So they are trying to say it increases in size during menstruation. It's basically trying to say that every menstrual cycle it becomes bigger in size. It's very painful and it itches a lot to the patient. And the treatment of scar endometriosis is local excision. So whether it is a cesarean scar endometriosis or episiotomy scar endometriosis, we do a local excision of this. All right. So yes, I'm sure all of you got that correct. Right, guys, let's see the next one. Tubectomy is done at which part of the fallopian tube and why? Now, was this the question? Because a lot of you said, what is the tubectomy question? So yes, what did you guys answer? Yes, where do you want to like get the tube? Ampulla, uniform thickness of muscle. Ampulla is widest. That's why isthmic, uniform thickness of muscle. Isthmus, narrowest. Come, guys. Yes, guys. Isthmic is not the narrowest area, by the way. You keep saying that. I don't know why. The interstitial part, the intramural part, this part of the tube is the narrowest. Okay. So, narrow part, okay, isthmus is narrow, but narrowest is the interstitial part of the tube, the part within the uterine muscle. Anyway, answer is D, isthmus. Okay, so isthmus you want to do the ligation at the isthmus. Don't say even isthma ampullary, because if you do the isthmic ligation, the two cut ends are like this. But if you do a isthma ampullary ligation, then the two cut ends are like this. So this the place isthmic ligation you want to do and not isthma ampullary. Why? Because once you do a tubectomy, you're doing it when a family is complete. But unfortunately, sometimes a woman may lose her children, or she may have a divorce, and in separation, the husband takes over the children, whatever. If she's not having the children and she wants to have more children now, so you have to do a reanastomosis. So when you do a tubectomy, you keep in mind that one day you may have to reverse it, or you do a tubectomy and somebody else in some other city might have to reverse it because this woman wants to have more children. So that time, it's a very successful reanastomosis if it is a tubectomy which was done at the isthmus, because the cut ends are uniform. So these two cut ends, okay, these two cut ends, if you reanastomose, it will be easier. Whereas if it is isthma ampullary, then the reanastomosis is not so easy and not so successful. So reanastomosis at the isthmus, it is up to 80% successful. So that's why we do it at the isthmus. All right, I think all of you got that. Ampulla, inner muscular, I don't know. Ampulla, we never do a ligation, because if you do ligation at the ampulla, you injured the ampulla, and the ampulla is the place where the fertilization has to happen. So next pregnancy, there is no ampulla left. So please never say isthma ampullary or ampullary. Okay. So it is the isthmus. We always do isthmic ligation and not even isthma ampullary junction. It is erroneously mentioned in many books. I don't know why. Always isthmic. I mean, day in and day out we do tubectomies, and I have done a lot of reanastomosis. We do laparoscopic reanastomosis, and we know that the ones which are on the isthmus are the easy ones to do. All right, so let's move on. Which of the following is the tumor marker of ovarian solid cystic mass? I don't know what was a solid or cystic both. You know, solid cystic together is a variegated tumor, and a variegated tumor is a bad tumor to have. So there is no CA125, because a solid cystic tumor, a variegated tumor of the ovary, is a classical ovarian tumor where CA125 is high. So was CA125 there in the choices? Because if it is there, I would have marked that. Cystic solid together means cystic solid area together. It is known as a variegated tumor, and ovarian tumors, variegated ovarian tumor, cystic solid one is classically the ovarian malignancy which we see, and CA125 is the classical which we say. Although HER2 new also will be increased in ovarian tumor. So in the choices given to me, I will mark C. HER2 new is the oncogene which I will be marking here. If CA125 was there, I would have probably marked that. What was the answer? Which one? Which one you had a problem? This one? Isthmus is, yes, that's the answer. Oh, I did not mark it. I said it 5 times, I think. Never mind. So choice D was the best answer. Now come back to this. What was the uh, oh, you mean to say, okay, I get your confusion. Yeah, you're saying isthmus is the best area because it's the uniform thickness of muscle, or since isthmus is the narrowest. I don't know what was the. I mean, I want to say isthmus because the cut ends are uniform. The cut ends are uniform diameter. So if that is then I think, yeah, then maybe you can say C is the better answer. Yes, because the language here is not very good. So yes, not because this is the narrowest, I can change my answer to C if you guys really see that it was the better language recall in this one. I can change my answer to C. It is definitely the isthmus because it's the uniform diameter. Okay, fine. Thanks for reminding me. I just marked isthmus because I saw that. Okay, let's move on. CA125 was given, is it? There was a question, perhaps we'll come to that. CA105, LDH, HCG, AFP. If it was Upender Singh Tanwar's choices, CA185, he says it is CA125, lactic dehydrogenase, HCG, and alpha fetoprotein. Then, my friend, you have just told what I was saying, that cystic solid tumor, variegated appearance tumor, then the best answer is always CA125. Okay, if these were the choices, I'll say C. Otherwise, what you said, Upender, with that I'll go with CA105. Okay. CA99 is, if even if it is there, it is, yes, CA99 might be, CA99 might be there in the choices. It is increased in ovarian tumors also, but not the major tumor marker. Okay, it's more for gut cancers, pancreatic cancers. Now, cancer staging, CA cervix cancer staging, extending till pelvic side wall, that is 3B. That is straight away 3B. Right. There is that IUCD question is coming, guys. Let's move on. Not a contraindication of external cephalic version. Yes, external cephalic version, you hold the baby in a from outside the mother's abdomen under ultrasound guidance, and you turn the baby from a breech to a favorable cephalic presentation, or from a transverse slide to a favorable cephalic presentation. So, external cephalic version is done at 36 weeks in a primigravida and 37 weeks in a multigravida, because at these times the uterus is relaxed and the liquor is reducing and the baby is bigger than 32 weeks. So that's why you wait for the baby to become bigger and the head is bigger. So when you turn the baby, he stays turned. That's why you do it at 36 weeks or 37 weeks. All right, that's the time to do it. But there is a contraindication if there is a placenta previa. Anyway, you're not going to do a normal delivery. And when there is a twin pregnancy, you can't do it easily. And primigravida is no contraindication. Premature rupture of membranes is a contraindication. What are the other choices? I mean, if this was not the choice, second shift, first shift, I don't know why these guys kept doing that. I think after the recent fiasco about the exams, they're being extra cautious. All right, fine. So this one is settled. Let's move on. Okay, what is the maneuver shown in this image? You know, there's a baby hanging, and there's a baby hanging with the head inside. A doctor is holding the legs. See the grip of the legs, you know, the finger is like this. These are the legs of the baby, and there's a 3-finger grip like this. This is the grip in between the two ankles. You put your finger, and then around the ankles you put the other 2 fingers. So then this grip is to hold the leg, and then you pull the legs up while turning the baby in a large arc of a circle. So this, when you turn the baby in a large arc of a circle, this head comes out of the perineum. This is the classical Bern-Marshall technique for the aftercoming head of breech. So a lot of you were saying that there was an aftercoming head of breech question. So there it is. So it is a Bern-Marshall technique. So what was the question? So silly mistake ho gaya, answer hai. Right, Pradeep, don't worry. I hope you've done the other questions well. Multiple pregnancy was there, evening shift. Okay, fine. This is the easy one, Bern-Marshall technique. All of you have seen that. Let's move on. So identify the uterus shown in this image. Now this is a very simple question. There are two uterus shown here and there are two cervices and two vagina. So it's a didelphys and bicollis. Two vaginas are there. Alright, didelphys, bicollis. But bicollis was not asked here. Okay. There's one question on chocolate cyst. What is the question on chocolate cyst, my friend? This is an easy one. Let's move on. While my friend recalls the chocolate cyst, Dr. Divya, what is the question on chocolate cyst? Now, I don't know what was this image. Identify the image shown here. Intramural fibroid, adenomyoma, endometriosis, and myomatous polyp. So, it's very difficult to make out from the picture given to me. Can you describe the picture given to me? Gross image was given. Fibroid. This was not the image. Burn Marshall option. Javanelli procedure. Javanelli procedure is for the shoulder dystocia, my friend. Anyway, chocolate cyst was given, Divya. All right. If this was not, I mean, endometriosis has a chocolate cyst. Okay, fine. If there was a chocolate cyst shown, chocolate cyst, if it is on an ultrasound, it looks like a ground glass cyst. Ground glass cyst. I don't know whether that was the picture of the ultrasound, but yes, chocolate cyst is endometriosis. And I don't know whether this looks like a fibroid on the uterus, small fibroid on the uterus. I don't know, but what was the picture given to you guys? So I don't remember any such image. It was a cut section. Okay. All right, guys. So chocolate cyst is there, and uterus. If there's a cut section, then they're trying to show you an adenomyosis generally. But I cannot imagine and give an imaginative answer. So what is there in front of me? I'm giving an answer. Let's move on. So next question here is, a woman presents with twin pregnancy. On ultrasound, the estimated age of one fetus is 1 month more than the other fetus. What is the diagnosis? So in the scenario given to me, there are two fetus in a uterus, and one is 1 month bigger than the other one. So this happens to twins many times. When one baby is IUGR and one baby is normal growth, it can happen, isn't it? So mostly that is what is going to happen. But in the choices given here, we have to go with superfetation. That one baby was implanted, let's say, in the ovulation in August, and then she ovulated in spite of being pregnant in the next month. And in September, she had another intercourse, and the second oocyte was fertilized, and the second baby was implanted after 1 month. So that is a superfetation, and that's why there's a 1 month discrepancy. So that's the scenario made out here. But superfetation is extremely rare in humans. A few cases which have been presented about the humans, all those cases are not without a doubt, because superfetation is very difficult to prove. So it's a very common animal phenomena. It's not a very common human phenomena, superfetation. But in the scenario given in this question, I have to mark superfetation. But yes, please remember, the question can be asked that one baby is, let's say, is a pregnancy of 34 weeks, and one baby is by parameters 34 weeks, but the other baby is having a parameters of 30 weeks. So more likely the second baby is having an intrauterine growth restriction. All right, that is a more common scenario. Something like in a famous movie which was recently on the screens, has a very famous song. So there was a scene like this where they were twins and one baby is big and the other baby is small at term. So that's what is generally the second baby is an IUGR. Okay, but yes, in the scenario sent to me, this answer to this scenario is definitely a superfetation. Okay, so superfetation. All right, guys, let's move on. Okay, what are you guys writing? Okay, a 30-year-old lady, Gravatu Live 2, history of cervical lengthening. What is the surgery of choice? Come, guys, tell me the choices to this question. It is looking like a case of cervical elongation after 2 deliveries. So, what are you going to do? Yes, it's a case of prolapse, and in a woman who is 30 years of age, but she has 2 children. Everybody said Fothergill. Thank God for saying Fothergill. I hope none of you marked hysterectomy. Even if she had 4 children, I would have not said hysterectomy. Don't say that if a woman had 4 children and she's 30, I'll do a hysterectomy. A hysterectomy is a drastic surgery, and don't think that a woman is happy getting a hysterectomy done. Look, what private practitioners are doing and what is happening, in private practice, that hysterectomy is a rule for all women who have children. A lot of commerce is driving that option, okay? Otherwise, the ideal option for a woman is never hysterectomy at 30 years, okay? If she's having a prolapse, we'll try to keep the uterus back inside with a Fothergill repair or a Manchester repair. We are not going to do a hysterectomy. So, Fothergill repair, it involves fixing up the Macken rods and doing a pelvic floor repair. So, tightening the Macken rods will keep the uterus inside, and the pelvic floor repair will give the good strength to keep the uterus inside. So, that's why Fothergill repair, including a pelvic floor repair, is the best management of this case. All right. In a fertility preserving prolapse surgery, which bony landmark is used for suspension? There was a question about mesh, then there was a question about this. Was it all in one question? I mean, asking three prolapse surgery questions. I mean, there's a Fothergill question, there's a prolapse question with a requirement of fertility preservation, then there's a prolapse question about a mesh. I mean, these guys really got to the details of some very non-regularly asked questions. So that's why I was thinking, what was the the scenario of this question? It was abdominal surgery for prolapse, sacral promontory. Mesh was also, there's another question with mesh. Abdominal surgery for prolapse, that's what everybody is saying. So abdominal surgery for prolapse. So we call it abdominal cervicopexy, sling surgery. Abdominal cervicopexy. You open the abdomen, pull the uterus up and fix it to the sacrum, or you can fix it to the rectus sheath or to the anterior superior iliac spine. You can do that abdominally. So that is what is a sling surgery, abdominal cervicopexy, other name for sling. But I don't know what was, because a lot of questions with confusing options have been given to me. Point where mesh should be, that's another question then. Point where mesh should be attached by the needle, that's another question. It's coming next. Okay, fine. First shift, second shift, forget it. If this was the question, abdominal surgery for prolapse, that is known as the abdominal cervicopexy, which is also other name for the sling surgery. Now, for this question, fertility preservation, what is the bony landmark for the suspension? I'll go with the ischial spine. Okay, then depending on what question was asked. Then the next question is, a pregnant woman presents with IUCD inside, the thread is clearly visible. One wants to keep the pregnancy going. What do you want to do? So when there's a pregnancy and there's a IUCD with the pregnancy, so this is the gestational sac and there's a fetus here and the IUCD is lying here, let's say somewhere like this, and the thread is visible. Thread is visible. What do you do? Always the option is, always the management is to remove the thread first, because with an IUCD plus pregnancy is equal to more than 50% chances of abortion. All right. So even if you remove it, there is still a residual chance of 25% abortion to happen, even if you remove it. But that is better than keeping the IUCD inside. So always, if you can see the thread, take the thread out. So no, remove gently, and that is the best option in this question. If it is not seen, Pradeep Goyal, then you keep the IUCD inside and hope that she doesn't abort because of that. Because with the IUCD inside, it's up to a 50% chance of abortion. A 45-year-old woman with a history of cervical erosion and spotting since 2 months. What are the next best step? Yeah, see, we were telling you that there's a question on cervical erosion also. So postcoital bleeding, I'll always say colposcopic biopsy. Okay, now this is a case of cervical erosion and spotting for 2 months. What are you guys going to say? Yes, I'm going to say liquid based cytology and do a human papillomavirus, the type of serology, type of DNA, what it is. Okay. So, HPV and LBC. Yeah, that's what a lot of you were saying. So, there was an answer where there was a question where the answer was liquid based cytology and HPV DNA assessment. So, this is that answer. Okay, this is where it is easy to answer it immediately. Okay, guys, next question. A Grada 5 para 4 woman comes for routine sonography for the first time. She has earlier 4 daughters and wants a boy this time and asks, she is asking for sex determination. So, please, we don't do sex determination. This is not an indication for doing sex determination. There are only some disorders like a Duchenne's, muscular dystrophy, where if next time it's a boy, then you may want to know if it's a boy and you may want to abort it. So, some very rare indications, or if there is a congenital adrenal hyperplasia, there where you want to do this. So, where you want to know the sex of the baby. Otherwise, there is no indication for you to do the diagnosis of the sex of the baby. Sex determination is not done. So, I don't know whatever the choice is here. There is only one choice which is making sense, that do only routine antenatal checkup and do not check for the sex. Okay. So, we do not do sex determination in any given situation till there is a chance that some disorders are female specific, some disorders are male specific. So, if there is a Duchenne muscular dystrophy, then I don't want a male child who's probably the mother had a Duchenne's baby earlier. If it is a male child, then we want to probably abort it. If it's a female child, then we'll continue the pregnancy, something like that. Then only we'll do a assessment of the sex of the baby. Otherwise, we will not do it in any given situation. All right. Maybe the choices are a little muddled up, but we will definitely not tell the sex. Okay, guys, next question. A pregnant lady with known asthma having postpartum hemorrhage, which drug is contraindicated? That was a fairly simple question. All of you know this one, I'm sure. Yes, come on, guys, quickly, at least one of you answer, then we'll move on. You can give methyl ergometrin, you can give oxytocin, which one you cannot give? Come, I'll give you a lot of hint here. All right, so B, at least one of you, Pradeep has answered, Rich has answered, and Chota Doctor, Saurabh Ghosh, everybody's answering correct. So, carboprost. Carboprost is the one, PGF2 alpha. PGF2 alpha is going to cause bronchospasm. Misoprostol you can give. All right, misoprostol you can give. We use it for inductions also if there's an asthmatic, it's not a contraindication. Okay, a young woman presents with prolapse, a mesh is being placed. Where is this mesh fixed to? Yes. Yes, which level do you fix it? Again, you fix it to the level of the ischial spines. Of course, it goes near the tuberosities, but you're fixing it at the level of the ischial spine, because that's the place where you are doing all the hitching. All right, the sacrotuberous ligament is also there. So, you want to make sure that it's at the level of the ischial spine, at the level of the mid pelvis, you want to fix all this mesh. So, I hope all of you have answered that. What have you answered? Sacral promontory. See, sacral promontory, you're going to put the slings. Okay, sacral promontory, you want to put the slings. But yes, depending on what question was asked, again, that is the problem here. So, carboprost wale morning में था, okay, fine, that doesn't matter. Wherever it was asked. All right, so you're discussing about what to do. So, these were the questions which came to me. Anything else you want to ask me, guys? The questions which came to me, I've discussed, and with the confusing options all the time. But yes, the purpose of the exercise is to get the right choices so that we can make the proper questions for your question banks. So, anything else you want to ask me, guys? Any question which I've missed? Yes, there was one question which one student sent me. Let me see if that has been discussed here. Um, a 20-year-old patient came to the OPD with 10 weeks of gestation and she does not want to continue pregnancy. She wants medical management. What will you do? At 10 weeks of gestation. She's come with 10 weeks of gestation. Was this a question? How can you do an MTP at 10 weeks of gestation? Was this a question like that? Yes. Ovulation wala question, Pradeep, is that what is the state of the oocyte when it comes out in ovulation? That state of the oocyte is second meiotic division in the metaphase stage. So we call it a metaphase 2 oocyte. Metaphase 2 means second meiotic division में first meiotic में भी metaphase होगा, second में भी metaphase होगा. So second meiotic division, the metaphase stage, metaphase 2 oocyte we say. MTP, mifepristone per misoprostol. 10 weeks pregnancy mode of MTP. Okay. 10 weeks pregnancy mode of MTP, Domati. It is 10 weeks of pregnancy mode of MTP. If that was the question, then go and say suction evacuation. If they want to say medical abortion, then we can give mifepristone, misoprostol. Yes, that will still cause an abortion. Okay, but the chance of success will be much lesser. Zona hatching after 6 days of fertilization. That is correct. Hatching happens on the 6th day. That's why implantation earliest happens on the 6th day. So, I don't know in what context you were giving me that. A lady with first degree vaginal delivery, last 2 LSCS, first vaginal delivery, and I don't know, he took it off. Implantation wala 5th day or 8th day? Pradeep, both are correct. If a person, if they ask you implantation earliest, it is not 5th day, earliest is 6th day. 5th day implantation doesn't happen. Why? Earliest is 6th day. We never say 5th day. Why? Because if it is happening till the 5th day, implantation का 5th day पे हो जाएगा, तो how can you say emergency contraception 5th day तक दे सकते हैं? Emergency contraception is only 3 days, but when you use IUCD, you can go up to 5 days. Why? Because implantation earliest happens on the 6th day. That's how I always correlate in the class for you. That earliest implantation happens on the 6th day. That's why IUCD is that emergency contraceptive method which can be given up to 5 days. So 5th day पे implantation नहीं होता है, 6th day पे earliest. Otherwise, it can go up to day 10th of fertilization. So let's not get about any more confusion on that. Active herpes simplex virus infection. I'll do a cesarean section. There was a question about 2 previous LSA's birth. Now she has genital herpes. Anyway, 2 previous LSA's. I'll do a repeat cesarean. All right. So please tell the answer for PCP NDT. PCP NDT. What was the question? There was a question that you cannot do sex treatment. I mean, the mother wants to know about sex of the next baby. You will definitely not say. Let's say, even if she asks me, I have to report to the police. A woman asks me that I am pregnant, please tell me the sex of the child. That itself is reason for me to inform the police. I mean, of course, most of the time they say, please don't ask. If you ask me one more, I'm going to tell the police. That's what we generally do. But by the law, we are supposed to inform the police because, you know, when women don't know about things like that way, 100 women coming to the OPD in a government hospital, 99 will be in the police station because everybody in our country, unfortunately, is going to ask you, I want a male child. So if every lady is going to ask us that, then we keep telling the police every time, then all pregnant ladies will be managed in the prisons. So yes, we always warn them that don't ask, but if they repeatedly ask us, then we have to inform the authorities. PCP I have said, normal vaginal delivery, 6 to 8 days, option tha sir, 6 to 8 days is fine. Fertilization, implantation time, first was 5th, second was 8th. So go ahead and mark 8th, that is fine. Please check my question. Swapnil Basu. Normal vaginal delivery. What do you want to ask me, Swapnil, about more elective LSAs? You give me questions in segments, Swapnil. Can you make the full question? Endocervical polyp, no question has been given to me. Classical or cesarean? Previous LSAs, 2 LSAs, third also I'll do LSAs. Still there is some other question, some other variation. Swapnil, you have to give me a question. That herpes simplex virus question, you have to send me all the choices. And you can send me on the same forum. You know, I'll be seeing this tomorrow evening again. And that herpes simplex question, what were the choices? If you send me, I'll send you the exact answer on the same forum. I'll write on the chat. Do the test for sex, but do not reveal it to the parents. No, not at all. We don't do the test at all. We don't look for sex. A woman had a cesarean 20 years ago. Image shows a uterus outside the introitus. Internal os admits one finger. Inversion myometrial prolapse. If the internal os is there, if the internal os is there, then it cannot be an inversion, right? If the internal os is there, look, if the uterus is like this and it is inverted like this, you will not see the internal os, you will only see the fundus. See, if the uterus is like this and it gets inverted, suppose it gets inverted, so you will see the uterus like this. So you will not feel the internal os, whether it's acute inversion or a chronic inversion. So if the uterus is like this, suppose the uterus is like this in the vagina here, and now you're saying that you're able to see the internal os here like this, and it has come out of the vagina here, it has come out here. So if you can feel the internal os here in a PV, that means it's a case of prolapse. I don't know what was the choices given to you. By the story which you sent me, it looks like a case of prolapse. Active HSV infection, I will go ahead and do a cesarean section. See, if there is a sex determination required for a particular anomaly, that is, there is I told you that, depending on the question, whichever forum you've seen that question, your Mr. Mahinder Patel, wherever you've seen that. So you have to give me the right choices to give you the right answer. So when a mother has 4 daughters and now she wants to know the sex of the baby, I will definitely not look for the sex of the baby, and definitely not, even if I know when I'm doing the ultrasound it's a large baby, I'll definitely know the sex immediately while I'm doing the the ultrasound. I'll definitely be able to make out, but I'm not going to tell the sex to the mother. There is no way I'm going to tell that just for sex determination, because if it is done for the purpose of having a boy child, then she's going to, if it is a female, she's going to go and get an abortion done. This is exactly the reason why we have the PCPNDT Act, because we don't want to tell the sex in any condition till it is medically indicated. Very simple. Yes, Mohammed Nihad, I'm agree with your information which you given. Prolapse was not an option. Management of bilateral corneal block. Dr. Lulu, your question is very interesting. Let me see what you are, the options you're giving me. I'm not getting into it. Infertile couple, HSG shows bilateral block tubes. No, if it is Mohammed Nihad, if it is bilateral corneal block, it's because HSG sometimes cannot open the blocks and there's a tubal spasm. So based on HSG, I'll not do IVF. Then I will, after a corneal block on the HSG, I'll go ahead and do a laparoscopy. Goodell sign, of course. Goodell sign, all of you know. Yes. Shadwick's bluish discoloration. Goodell's is softening of the cervix, and Hagar is softening of the isthmus. Good questions, simple questions. 10 weeks MTP, suction evacuation, if that was asked. Okay. Dr. Milind, you have to take a PrepLadder subscription. Nowadays, we are not selling the individual apps, but if you want the individual app, you can send a request to PrepLadder, and if a lot of people ask, then they will give individual apps, hopefully. So far, we are just giving apps, we are giving the complete app to everybody. Nugent score, yes, that was the other question which the Nugent score, of course, is for the diagnosis of bacterial vaginosis. If you see 7 rods, more than 7 rods, then it is a definitive, and 4 to 6 rods is indeterminate. So if you see rods more than 7 in the on the slides, then it is suggestive of a active bacterial vaginosis infection. So, but Nugent's is a microbiology phenomena mostly. We as clinicians use the Amsel's criteria. Amsel's criteria is 5 options, and any 3 of them is bacterial vaginosis. Nugent is a score based on a microscopy of a stained slide, and in that, if you see more than 7 rods, then you think in terms of a bacterial vaginosis. Yes. So, a lot of controversies as usual about the recall, and now they've compounded the controversies by asking, by giving 2 shifts to the same exam. So, yes, please have the patience of writing all your questions and the formatted questions in this, and we can always get back to you on the PrepLadder forum with the proper formatted questions and the proper answers, definitely in the Q bank at least. All right, guys. So I hope all of you have done very well, and each one of you will get what you want in your life. All right. So all the best with that, and keep reading very hard.